Good morning, I'm Dr. Martin. We're here at the Institute of Regenerative Education, and we're going to talk about something that is really starting to pick up speed. And it actually has taken me by surprise. Most of you who are coming to this page are coming from integrated medicine standpoints, chiropractic standpoints, orthobiologic standpoints, podiatric, integrated chiro. The penetration of regenerative medicine in standard practice of medicine is actually relatively small. If we look at a total population in the United States, we have somewhere on the order of 200,000 chiropractors. We have 800,000 licensed physicians. We have conservatively 400,000 licensed nurse practitioners. We have about 150, 200,000 licensed PAs. And out of that huge population of people, conservatively, 5% are using regenerative medicine. You might think that it's a lot of people. You've set up practice and maybe you're, in Detroit or Jacksonville, or maybe you're in Plano, Texas, or you're in, Orange County, California. And you're like, well, I definitely know that there's another doctor, somewhere in my town that's using biologics. Well, think about the number of orthopedic surgeons that are in Las Vegas. I think there's something like 70 orthopedic surgeons, maybe 150 in Las Vegas proper. In Southern California, I don't know, there's probably 4,000 orthopedic surgeons. So wherever you are, if you're thinking to yourself, oh, well, I know this one clinic, that's not a lot of competition, right? And the penetration is really only with regard to PRP. We see very little in the way of use of umbilical cord derived products because it's still experimental use. And to be perfectly honest, there's a huge education gap that we've been trying to fill personally for quite some time here, but still information travels slowly. Now, where information has not traveled slowly is in dental circles. And it has happened that I have had multiple requests to do a video specifically with regard to dental application. Now, there are conservatively 200, maybe 225,000 licensed dentists in the United States. Around 25% of them are using some manner of regenerative therapy in the course of their procedures. It's most commonly PRP or PRF. There is no penetration for umbilical cord derived products. And again, I think the primary issue with that is education. There are some PRP and in particular PRF companies that specifically targeted dentists. And they've done a wonderful job of running a dentist and giving them something better than just, well, let's let the body heal itself, right? And I'm never a big fan of letting the body heal itself because, and any dentist will tell you this, the root of most disease can be found in the teeth. And you can really determine the health of a patient by just simply looking at the health of their teeth. If they have horrible looking teeth, think any meth addict, right? They're probably not very healthy everywhere else. And so I did a very deep dive over the weekend and I looked pretty aggressively into the literature. And like always, when I introduce a new subject, we will put some relevant peer-reviewed references for you to review so you can pull the articles and you can read them for yourself. But this lecture is a toothy subject. And this is in fact a tooth, right? Everyone's kind of joking about what this is, but this is actually a dental implant, right? And this is the implant here. We can make this a little more poignant, right? Here's the implant here, right? And these are all the screws that are going into the bone, right? Now, if we review just a little bit of elementary anatomy, right? We have gum tissue on the outside. Everyone can see the gum. We have alveolar bone, right? Gum tissue is type 1 and type 3 collagen. Bone is, of course, type 1. And in normal, healthy teeth, we have we have a periodontal ligament, my apologies. And that periodontal ligament in a normal, healthy tooth would sit here, in between the tooth and its roots, and the bone and the gum. That periodontal ligament does not exist when we do a dental extraction or a dental implant. There is simply titanium right up against bone. And in typical application for biologics, PRF is commonly used. We're drawing blood, we're spinning it down, we're getting the PRF fraction, right? And we're using a little bit to rehydrate the bone graft that we're applying before we seat the implant. And then some providers are actually, after hydrating the bone graft, applying a little bit in these periodontal tissues, right? In particular in the gum, and here in and around the alveolar bone, sometimes sprinkling it around, sometimes injecting in the gum itself, because periodontal ligament is no longer there. Now, what's the problem with using PRF or PRP? And we get into this quite a lot. Most know. I've been a pain doctor for 25 years. I started using PRP in 2009. I stopped using PRP in 2015, and I haven't used it since. Why? Well, we talk all the time, and most of you who have seen my lectures, you know, we do this Martin triangle where we have function at the top, we have inflammation here, and we have collagenic differentiation here. And anything that increases inflammation decreases collagenic differentiation and decreases function. Well, how does PRF function? Well, if we take a comparison between, say, PRF and Wharton's jelly, and in this case, probably a lyophilized Wharton's jelly, something that Platinum calls nano DPM, dehydrated particulate matrix, we know that all autologous biologics work by way of an M1 macrophage response, meaning that they will elevate IL-1 beta, elevate IL-6, elevate TNF alpha. Now, it does stimulate some inflammation. It does bring in some growth factors and some new blood to the area. But there is literature that demonstrates that inflammation, unregulated, can impair osteogenesis. I'm going to repeat that. There is some literature that inflammation, left unmitigated, can impair osteogenic differentiation, meaning osteoblast formation. Now, does this sound familiar to all of you? Well, it should, right? Most of you may have read an article by Dr. Ashim Gupta, personal colleague of mine. He and I published a paper on adhesive capsulitis of the shoulder back in 2023. Avoid RBCs in PRP if at all possible. Because when you put PRP into, say, a knee joint, the red blood cells die in 3 to 5 days. They release heme, they release iron, they induce an inflammatory reaction, and that inflammatory reaction is catabolic. And according to Dr. Gupta, that catabolic response can be as potent as the catabolic response from steroids and break down articular cartilage, which is type 2 collagen. Well, a very similar process happens when we inject PRF, and in particular in patients that lack the ability to down-regulate inflammation normally. Take anyone who's had 2 COVID vaccines and multiple boosters, they're immunocompromised. Any patient with autoimmune issues, they're immunocompromised. Chronic Lyme, chronic mold, any diabetic, they are functionally immunocompromised. And so when you put PRF in and around that dental implant, you're going to see inflammation that's going to last 4-5 days. It's going to be very, very painful for the patient. Notwithstanding the fact that when you inject PRF, practically speaking, you have to inject it with a damn harpoon. You're looking at a 22 gauge needle, and it's very painful when you do that injection, even if you do a dental block. Okay, so if PRF works on an M1 macrophage paradigm, and all right, Dr. Martin, we're following along with you here, right? It elevates IL-1 beta, elevates IL-6, elevates TNF-alpha, and could potentially inhibit osteoblastic formation if that patient was immunocompromised or just not very healthy. What about lyophilized Wharton's jelly? Well, we know that umbilical cord-derived biologics work by way of an M2 pathway. They downregulate IL-1 beta. They downregulate TNF-alpha. They downregulate IL-6. They upregulate IL-10. They upregulate ARG1. They have a net down regulatory response on inflammation. Well, heck, that's great. Because let me tell you, driving a big titanium, implant into the jaw causes some inflammation. It's really painful. I know, I've had it done. But is there anything else in Wharton's jelly that might improve this paradigm? Well, we know that Wharton's jelly histologically is type 1 collagen, type 3 collagen, hyaluronic acid, extracellular matrix, and a little bit of type 2 collagen. There's also hyaluronin in lyophilized Wharton's jelly. Well, this is fabulous. Hyaluronin downregulates inflammation. Alveolar bone is type 1 collagen. The gum itself is type 1 and type 3 collagen. This is looking good, right? We're putting in the collagen-based building blocks necessary for the body to repair itself at a cellular level. Remember, we can't use any human cell and tissue product, not PRF, not Wharton's jelly, to diagnose, treat, cure, or prevent disease. And we put it up here like we always do, right? The FDA is our friend, right? And so we're not going to make any claims with how we're using a biologic, whether it's lyophilized or whether it's autologous, but we can't use this to heal anything. We're not healing anything, right? All we're doing is putting in the collagen-based building blocks for the body to repair itself at a cellular level. But based on this Martin triangle, I had a doctor who got really upset that I called it after myself, but let's be fair, I'm the one that created it, so I might as well give it my own name. If I'm using Wharton's jelly and I'm down-regulating inflammation, well, I'm creating an environment of homeostasis. If I've created an environment of homeostasis, now my body can build at a cellular level. And we actually have the opportunity for enhanced collagenic differentiation because I have that type 1 and type 3 collagen, and I also have that hyaluronin, and I have that extracellular matrix. So ultimately, function improves, and the function that I'm looking for is the body's function. The body's ability to generate new osteoblasts and seat this dental implant so that ideally, from a patient perspective, the time to load decreases. Now, practically speaking, how would you apply a Wharton's jelly? Well, no different than you would PRF. Reconstitute the lyophilized product in 2 cc's of saline. Use about a half cc to rehydrate the bone cement, right? Throw in your bone cement. Now you've got another 1.5 cc's, and you can sprinkle it in the gum line, anterior and posterior, outside, inside, right? So you're stimulating type 1 and type 3 collagenic differentiation in the gum tissue, osteoblastic differentiation in the alveolar bone. That's hot. That's really, really hot. You don't have to draw blood, right? You don't have to monkey around for 40 minutes. You know, I talked to a dentist who's using A2M. An hour and a half. An hour and a half. Well, I mean, you know, I'm not a huge fan of the dentist anyway, no offense, right? Because I just don't like my face getting drilled on. I will say the guy who did my dental implant, he used some CT guided like robot thing to do the implant. Fabulous. Absolutely fabulous. But by and large, I'm not a huge fan. I mean, when they measure your dental pockets, oh my God, that's brutally painful, right? I mean, they should give you like a shot of tequila or something before they like measure the depth of your pockets. Ugh. Brutal. Anyway, I digress. This is what we're after, right? Let's put in the collagen-based building blocks for the body to repair itself at a cellular level, but let's also down-regulate inflammation so we put the body in a position where it can do so. We create an element of homeostasis so the body can repair itself at a cellular level. That's fabulous. Now, does every dentist do implants? No. And so is there application for something like a lyophilized Wharton's jelly, something like nano DPM, outside dental implants? Well, I broke this down into periodontal ligament present and absent, right? It's absent in dental implants, and we just reviewed that, right? It's present in any gum disease. It's present in any furcation where you've got molars that are really close to each other like wisdom teeth, and you start to lose gum tissue, periodontal tissue, even bone between those molars, right? And post-op. If we've done any periodontal work, right, root canal, those type things, there can be damage to the periodontal ligament, which is what? Oh, it's type 1 and type 3 collagen. And so if I just did a root canal on a patient, is that going to cause some inflammation? Yeah. It's really, really painful, all right? So if I'm using PRF post, I can't even imagine. I mean, my tooth always aches to the point where I want to take a sledgehammer and just hammer my own jaw after a root canal. I can't even imagine if it was just all swollen and inflamed in addition to that for 4 or 5 days. This is a no-brainer. It's really a no-brainer. I mean, some of these PRP kits, the PRF kits, are brutally expensive. They're $400. A2M, $800, $1,000, $1,200. Lyophilized Wharton's jelly, $250. So if I'm positioning this for a patient with a dental implant, would I position this as a regenerative dental implant? Sure, right? There's actually some regenerative potential with Wharton's jelly. Restorative, another nice word, right? I anticipate that this process 2-3 years now, 2-3 years from now will be the norm. No one will use PRF. No one wants to draw blood and have, Mrs. Smith come in and she's a little old lady and she's dehydrated because they all are, and you've stabbed her 5 times and can't get blood, and then you do a dental implant and you said you're going to do it with PRF, and you made this big deal about doing it with PRF, and then you couldn't get blood. So you can't do the implant with PRF. And she's 78. And if she's 78 and osteopenic, we know that her bones are a bit soft. She's probably not taking her calcium, magnesium, and vitamin D on a regular basis. And so the likelihood that her dental implant doesn't take is very, very high. And what does she remember when you test the integrity of that implant and it fails? I can tell you what she remembers. She remembers you selling her on doing PRF, giving her nothing but lots of bruises and a lot of pain, and then not doing the PRF and the implant failed, right? Guess what you get to do then? Oh yeah, you get to eat the cost of that implant. Because there's no way she's paying for it. Because you sold her on this and you couldn't get blood. And then her implant failed, which of course it did, right? She's osteopenic. Wouldn't it be better to not have to draw blood? To not have to stab a patient with a 22 gauge harpoon and instead reconstitute something like nano DPM and 2 cc's of saline? And if you wanted to do local injections in a round, you can drive a 30 gauge needle and push that product no problem. No worry about 45 minutes spinning it. No worry about what speed or what rate you're going to spin it at. Single spin, double spin, leukocyte rich, leukocyte poor. None of that. Just simple, dose specific, reliable, shelf stable product for 2 years that you just reconstitute with saline and go. I am not a smart guy. I say this all the time. I'm never going to be the smartest guy in the room. But what I try to educate to are practical, evidence-based, and duplicable paradigms that anyone can use anywhere in the country, anywhere in the world, and reasonably expect to get a decent outcome. Now, I know most providers do a single application of PRF at the time of implant. Would I do a single application of something like nano DPM? No. I would probably use it intraoperatively, and I'd probably drop some more again 4 weeks later. The process of osseous integration isn't static. It can be 3, 4, 6 months. And if you have somebody who doesn't have very healthy bone, or they don't have very healthy habits, or they're eating at Chick-fil-A 3 times a day, and then going for a midnight snack at Del Taco with a super big gulp or a Slurpee from, 7-Eleven, how's that bone going to heal? Not very well. Not a whole lot of homeostasis going on with bunches of Chick-fil-A and a Slurpee. But this might make this a less toothy situation. I'm Dr. Martin. Have a very blessed day.